started. So what is an arterial blood gas? So an arterial blood gas is a blood test taken from an artery that measures the arterial gases such as oxygen and carbon dioxide. So in order to actually understand it, you need to know that the normal blood pH is between 7.35 and 7.45. Okay, a blood gas of below this, so below 7.35, is classed as acidotic. Okay, a blood gas of above 7.45 is alkalotic. So oxygen. An oxygen reading below the normal range is described as hypoxemia. If your oxygen is low, your body's pH will generally go down, provided that it's an acute thing, not a chronic thing. That's important to remember. An oxygen reading above the normal range is usually secondary to hyperventilation or over-oxygenation from oxygen therapy. If your body's oxygen is high, then your body's pH will tend to go up, causing alkalosis. So carbon dioxide. So carbon dioxide level above the normal range is called hypercapnia. This will cause your body's pH to go down generally. However, in patients with COPD and chronic retention, often they'll have a high carbon dioxide level and their pH will be normal. Therefore, their body is completely normalized to this, so it doesn't need any treatment whatsoever. A carbon dioxide level that is below the normal range is usually caused by hyperventilation, and this will create an alkalosis. Bicarbonate. So bicarbonate is a byproduct of your body's metabolism. Your blood brings bicarbonate to the lungs and then it is exhaled by carbon dioxide. Your kidneys help to regulate the bicarbonate levels and your blood pH balance. If your bicarbonate is high, your pH will go up, and if your bicarbonate is low, your pH will go down. It's often described as being in a lift. If your bicarb goes up, your pH goes up. If your bicarb goes down, your pH goes down. Okay. So base excess. This is another metabolic process. Okay, that's important to remember. So above the normal range, so +2 or -2 indicates an excess, and below indicates a deficit. So a low base excess either suggests a metabolic acidosis, so there's a DKA going on because your metabolic process has gone down, or your body is trying to compensate for a respiratory alkalosis caused by something like hyperventilation. So your bicarb will go down because of that, and your base excess will go down because of that, to try and counteract. So a high base S either suggests a metabolic alkalosis, or it's again gone up to compensate for a respiratory acidosis. Your body's always trying to correct the pH. So there's always when there's a reaction, there's a counteraction. There's always going to be some sort of interaction between the two. So if you're hypoxic and hypercapnic and your pH has gone down, then your metabolic process will speed up and your bicarb will go up and your base excess will go up to try and compensate for that. So this is just a little acid-base balance table. So obviously pH low is acidosis, high is alkalosis, carbon dioxide low generally causes alkalosis, high causes acidosis. The low is usually secondary to hyperventilation. The high is secondary to retention of carbon dioxide, either because of chronic obstructive pulmonary disease process or chronic cardiac failure, or acute on chronic cardiac failure. So it's important to remember that if your CO2 is high, but your pH has not changed, then it may well be a chronic hypercapnia, in which case you probably don't need to treat it. So oxygenation, a low oxygenation generally gives you acidosis, and it's described as hypoxia. However, again, if you're a CCF or a COPD or some sort of respiratory illness patient that has got chronic respiratory hypoxia, therefore your pH will not change. And again, you don't need any treatment for that. So if your PO2 levels are high, usually because of either a hyperventilation or an excess oxygen, then again, we can adjust this quite easily by breathing through a paper bag or reducing the amount of oxygen that we're giving them. So your bicarbonate, low is acidotic, high is alkalotic. Your base excess always goes up with your bicarb or down with your bicarb. Okay. So COPD patients, as I said before, look at the pH first. Are they acidotic or alkalotic? Look at the oxygen. It may well be normal for them, or it may well be. So I'd say 6 or above is normal, depending on the patient, of course, because they may well just be an early stage COPD, in which case they would be having quite normal oxygen saturations. See if the patient knows what their oxygen saturations are. That can also give you some aid to actually establish what is normal for them. High carbon dioxide level may be normal for them. So look at your pH. Is it just a normal pH for them? And in which case you probably don't need to give them much treatment. So is there any change in the bicarbonate and the base excess? Look for compensated changes. So if your pH is going down and your bicarb is going up, then it's likely they're going to end up in a respiratory acidosis. Okay. So just to bear that in mind, look at the changes that are taking place. So compensated changes. I like to use DKA because they always come in hyperventilating, look like death. They look really poorly. Why are they hyperventilating? Well, we know that hyperventilation causes high oxygen, low CO2, which will cause alkalosis. And what have they got? They've got a metabolic acidosis. So they're trying to compensate for the acidosis. This is our body's mechanism of trying to improve our pH levels. Otherwise, we just die, basically. We need to do something about it. So what do? Our body tells us to breathe fast to try and change that pH. Okay, so pH is 6.9, PaTO2 is high, PCO2 is low, which will cause an alkalosis, but the bicarbonate is low and the base excess is low, which will cause an acidosis. So they have a metabolic acidosis with respiratory alkalosis compensation mechanism. There's another tool that can be used. We don't often use it in the A&E department, but the anion gap is a very good measurement of the difference between negatively charged and positively charged electrolytes. So if the anion gap is higher than normal, then an anion gap metabolic acidosis can be diagnosed. So the anion gap is calculated by subtracting the serum concentrations of chloride and bicarbonate from the concentrations of sodium and potassium. Okay, I hope that makes sense. Any questions, or if you want to practice with some arterial blood gas sampling, please come and just show one of our ACPs or one of the doctors, and by all means get involved. Thank you very much. Goodbye.